Recurrence is a word that we hear frequently when we hear about breast cancer. But what does recurrence mean? Recurrence is when breast cancer comes back after a person has completed their initial breast cancer treatment. We asked Dr. Angela DeMichel to tell us more about breast cancer recurrence.
In general, recurrence refers to the process by which breast cancer cells can leave the breast and travel to another part of the body where they can grow. So a recurrence can actually happen within the breast where the cancer started, or it can happen locally. By that, we mean in the chest or in the lymph nodes that surround the breast, particularly the lymph nodes that are under the arm. Or it can be a distant recurrence. And by that, we mean breast cancer cells that have traveled to other parts of the body outside of the breast and lymph nodes, for example, the lungs or the liver or the bones. So those are all different kinds of recurrences, and those recurrences each have their own way of being treated, and they have different implications for prognosis. We have only recently started to understand how recurrence happens. For decades, it really was sort of a black box. We knew that women would get tumors in the breast, and we could even find the cells under the arm. And even though we would remove the tumor from all the places we could see, it would come back years or even decades later in other parts of the body. And how it managed to get to those other parts of the body was really a mystery until somewhat recently. We're now starting to understand that there are specialized cells within breast tumors, very rare cells, that have the ability to leave the breast. And we think that these cells enter the bloodstream, and they can either immediately find their way to another place, or they can enter what's called a dormant or sleeping phase, where the cells burrow into a specific area. Often this is the bone marrow, and the cells actually go to sleep. They stop dividing, they stop growing, sort of like a bear hibernating in a cave for the winter. They shut down for some period of time. Then, for reasons that still are not entirely clear, the cells can wake up, they can start dividing and growing again. They leave that niche where they have been protected, go back into the bloodstream, and travel to another part of the body.
Like most aspects of breast cancer and breast cancer treatment, the risk of experiencing a breast cancer recurrence is not one size fits all. Dr. DeMichel explained to us how the risk of recurrence can vary from patient to patient, and she told us a little bit about the tools that doctors use to help predict a patient's risk of recurrence.
The risk of recurrence is different for different types of breast cancer. So, triple negative breast cancer, those cancers that don't have estrogen or progesterone receptors and don't have HER2 receptors, those tumors tend to send out cells that will come back within the first 5 years of the cancer's discovery. And so even though those cells may have a dormant phase, it's very short. It's very similar for HER2 overexpressing tumors. Estrogen receptor positive breast cancers, however, seem to be fundamentally different. They can have a very long dormant phase, and they can then come back 10, 20, 30 years later. So we do really think about these different types of breast cancer as having different trajectories. And even though the process of recurrence is the same, it plays out differently depending on the type of breast cancer a patient has, and the time frames can be very different. Traditionally, we have used factors like the size of the tumor, whether or not there are lymph nodes involved and how many, and then more recently using genomic tests like the Oncotype Recurrence Score or MammaPrint or Breast Cancer Index. These are tests that look at the genes in the tumor, and based on the pattern of which genes are turned on and turned off, we can estimate the likelihood that there are cells that escape from the tumor and that have a possibility of coming back later. I think that what's also important here is eventually we will get to the point where we can test people and determined that they're not at risk of recurrence. We've never really had a way to tell someone that they will never recur. So every single patient worries about this, regardless of how low the risk is. We never can tell them it's zero. So I hope that in my lifetime, we'll reach a point where we actually know how to use these tests to tell us both who's currently at risk and who's never going to be at risk, and really remove that burden from patients' shoulders that they carry lifelong.
Dr. DeMichelle also explained that oncologists work closely with their patients to tailor their treatments to help them best prevent recurrence and maintain a good quality of life while on treatment.
Really trying to understand the magnitude of the risk factors really strongly into the decisions we make about which treatments we'll give. And as an oncologist, I spend a lot of time speaking with my patients about their level of risk and what I can recommend as enough treatment to have a good chance of eliminating the cells, but not so much treatment that they're going to be left with lifelong side effects. So really, we are always trying to figure out, based on the level of risk, how little treatment we can safely get away with to give patients the maximal amount of insurance against a recurrence. But we also are weighing that against the side effects that can come from these treatments. So the lower the risk, and particularly in very low risk patients, it could be very little extra treatment. It could just be surgery and radiation, or just the addition of an anti-estrogen pill and no chemotherapy. Whereas on the higher risk side, we start adding more intensive treatments, more chemotherapy, CDK4/6 inhibitors, and other things. So we are really trying to tailor the insurance against recurrence to the level of risk the patient has.